Thank you for joining us today. I'm Dr. Ed Diamond. I've been a lung doctor for 38 years in the Chicago area. I'm currently the medical director of the thoracic service line of the AMITA Health Network, which comprises over 15 facilities throughout the Chicagoland area. And I'm the immediate past president of the Chest Foundation. Welcome everyone to the Chicago stop of the Chest Foundation's National Listening Tour. We are honored in Chicago to be part of a national search for a solution for lung health access and equity. We started this process because we know that not everyone has equal access to healthcare. Not everyone with lung disease can get to a doctor or afford treatment. The problem that has been apparent to me during my 38 years as a pulmonary doctor. Our nation's healthcare resources are limited, and we need to distribute them in a manner that supports those most in need. The Chest Foundation wants to help, but we first need to more deeply understand the problems and the issues. Today, we want to listen and learn. We will hear from patients, doctors, healthcare experts, and local community leaders. We also have national leaders from the Chest Foundation who have started this conversation and are committed to enacting change. Welcome to our journey, and thank you so much for sharing our dream of the day we reach our destination and that everyone has adequate health care. I'll now turn it over to Brett Chase of the Chicago Sun-Times, where he reports on public health, who will be our moderator for the conversation.
Good evening. I'm Brett Chase. I am a reporter at the Chicago Sun-Times, where I wear a couple hats. I report on both environmental justice, which gives me an opportunity to write about the public health aspects of those communities. And also I'm part of a team that is covering the COVID pandemic. And I'm seeing, a great deal of, disparity and reporting on the disproportionate, the number of Black and brown patients that we're seeing. So this is a very critical issue. I'd like to start with an introduction of our hosts. It's Dr. Ayodeji Odigonsoy, is Assistant Professor of Medicine at the University of Chicago and a pulmonologist who specializes in interstitial lung diseases, genetics research, and healthcare disparities.
Thanks for having me.
Dr. Neeraj Desai is an Associate Professor of Medicine, Interventional Pulmonology, Fellowship Program Director at UIC, and Medical Director of Pulmonary Endoscopy and Interventional Pulmonology at AMITA Health.
Thanks for having me.
Thank you. Dr. Edward Diamond is the Medical Director of the Thoracic Service Line of the AMITA Healthcare Network and immediate past President of the Chest Foundation.
Thank you.
Dr. Sunita Kumar is a Professor of Pulmonary and Critical Care Medicine, Fellowship Program Director, and Medical Director of Sleep Program at Loyola University Medical Center.
Sorry, thank you for having me.
Kim French is an AMITA Health Vice President and Thoracic Service Line Director.
Hello, good evening, everyone.
Dr. Ada Arias, Dr. Ada Arias is a pulmonologist and recently served as the medical staff president at President St. Mary and Elizabeth Medical Center, where she now serves as the director of the respiratory department.
Thank you. Thank you for inviting me.
Rudy Anderson is the executive director of the Chest Foundation. He has spearheaded this listening tour to shed light on issues of trust, access, and equity that exist for patients with chronic lung disease. Chest Foundation is our host for this conversation. Rudy, the executive director, is going to explain a little bit about how this evening came to be and what the foundation's vision is on this listening tour.
Brett, really appreciate the warm introduction. First, again, thank you so much, everyone, for taking your time this evening to have this important conversation. There's a lot of ways to describe the Chest Foundation, but pretty much our mission hits the nail on the head, which is we champion lung health. And obviously there's a lot of ways that we can do that. many of which you will see us working through our healthcare providers and the support we can give many of our pulmonologists around the country. Sometimes it's through the patient education you may see on our website. And in other times, it might be actually in the community, like things like this, as much as we can be in the community right now, bringing the community together and being a thought leader. But one story that really kind of emulates and gives a clear understanding of who we are and why we do what we do is actually the conversation around Erin Popovich, who is unfortunately the late wife of Coach Greg Popovich of the San Antonio Spurs. Unfortunately, she passed away from chronic lung disease, interstitial lung disease. And it was a battle. It was truly a struggle that she had dealt with. And so most of us know Coach. We've seen him on television, whether it's about basketball or social justice initiatives. But in his private life, him and his family were really struggling to deal with everything that was going on with his wife's condition. And even with the great care that she had and the trust that she had with her pulmonologist, she still struggled, she still struggled immensely. And one of the things that was so clear to her and her provider was if they had all the resources in the world and they were still struggling to manage her disease and all the things that came with it and all the ways that their caregivers struggled, what is that like for everybody else that do not have the same type of resources? And so we were able to launch an endowment which has truly helped change the face of who we are and helped us start to have that conversation of what can we do beyond just patient education, really, but to have the conversation of what are we doing to provide access? What can we do to build trust and empower patients to have a different conversation with their provider? And what are the local interventions that we can impart upon our community? And so, with that, you might say, why us and why now? Obviously, I can't speak for any of you, but I think most of you probably have had that same tension and that feeling that we've had all summer. And although it has come to light this summer, like you, I'm a 37-year-old Black man, and much of the tension that I felt this summer is not tension that just sprung about because COVID came about. Many of the disparities that we talk about are things that have been occurring all our lives. And for us to be able to have it in a national conversation, bring it to light, but more importantly, have a different conversation to say, hey, this is gonna get a little uncomfortable. We're gonna talk about things that we just don't understand. And the best way for us to find meaningful solutions is to actually listen to those that understand it the most. And that's you, whether that be a patient, you as a community leader, or you as someone that is helping provide the care that's necessary for many folks that typically don't get that same care across the board. And so, as we have this conversation, I want you to know that there's going to be a lot more to come. And really, again, to touch on those three key areas for us is we want to think about what are we doing to build trust amongst doctors, patients, and our community? What are the answers that we can seek that can deliver resources within our community? And in the community that is all too often forgotten about, the ones that we don't hear about on Facebook or Twitter, but those that truly need the support from all of us. And lastly, how do we continue to raise the voice and profile of our community and those that need the help, no matter where they live? Because this is something that's not going to go away whenever we get a vaccine for COVID. Because guess what? Lung health is much more than just the pandemic that's arisen over the past year, but something that many folks have struggled with for a very long time. And so we want to let you know the commitment that we have to not only listening to you, but to raise your voice and make sure we're bringing solutions that really affect change within your own community. And so with that, I want to pass it off to Dr. Desai to talk a little bit about some of the things that we're seeing in the community so it can help frame up the conversation moving forward.
Thank you, Rudy. Every time we listen to this, it saddens us. And, it's such an important area, an important topic. And thank you and the Chess Foundation to shining a light on this. As our moderator, Brett mentioned, before I am a clinician in Chicago, and these are the patients, I see every day. I know firsthand the barriers that they face. I believe that physicians cannot effectively take care of patients in a vacuum, which does not consider patients' real life barriers to good health, which include socioeconomic status, cultural barriers, as well as racism amplified barriers. Disparities in healthcare occur when there is absence of health equity. Now, before COVID-19 epidemic, Chicagoans had problems with lung health and access to care. Really shocking numbers. African Americans are twice as likely to visit emergency departments for health conditions that primary provider could treat. In Chicago's low-income neighborhoods, up to 28% of residents have prescriptions they don't fill because of cost. Throughout Cook County, 12% of adults are living with chronic lung disease. Those who die from chronic lower respiratory disease are more likely to be African American. Asthma rates in the city's low income areas, and asthma is one of the most treatable conditions. Asthma rates in the city's low income areas are twice as high income areas. For people without access to healthcare, pulmonary conditions go undiagnosed. In Chicago, that describes more people than it should. Or, our poverty levels and percentage of people without health insurance are well above the national average. Now, certainly COVID-19 has amplified these stark differences, and it saddens us even further. Black and Latinx people in the United States are 3 times more likely to contract COVID-19 than their white neighbors, and nearly twice as likely to die. With over 11,000 active cases of COVID-19, and it's still spreading in our city, and the numbers keep going up every day. This is infecting both young and old, the prominent and the disadvantaged. The health outcomes have diverged. Chicago faces a huge problem, and our residents, and the problem is only going to get bigger, especially due to COVID-19. Now, the picture of lung health has forever changed. We have added more patients to the rosters of those who need long-term lung care treatment because of lasting effects of COVID-19, and can cause increasing demands of lung health care, such as pulmonary rehab. Those living in high poverty, Latinos, African Americans, were 2 times as likely to be hospitalized and or die of COVID-19 as the rest of the population in Chicago. Now, these pieces of data feed to the same outcome: drastic disparity in access to healthcare and to achieving good health. Our communities, in particular, those with socioeconomic barriers to good health, have been suffering and are now in more crisis within the pandemic. We really need to take time to listen and to act swiftly on what we learn with targeted and community partnered approach.
Thank you, Shirley, for being with us today. So Shirley Van Buren has had asthma since she was a child, but in the last year, this asthma has taken on to be a very severe condition, and which has significantly impacted her ability to continue working and to maintain activity levels that she once took for granted. So thank you again, Shirley, for being here. You were diagnosed with asthma as a child. So can you give us some background about how your condition has worsened over time?
It affected me from the time I was a child with the asthma, but it's worse now as I'm getting older. And since last year of September, My asthma have been so severe where I ended up in ICU, and it affected me in my life totally different because I'm not able to go back to work at this time because the COVID-19 had came out. So, and I'm not able to do anything, no kind of activities with my grandkids like I used to do. And so it affected me a whole lot.
And do you think your access to medications or some treatments have been affected in any way because of your asthma? Or do you have any problems with access to care?
Well, I did have access to care at one time because my job had stopped my insurance. So I didn't know what to do at that time. So I had went and signed up for public aid to see if I can get a medical card. So I was able to get a medical card at this time now. So I don't know how long it will last. You know, the medical card will last, so they would keep me on.
And then is there any other, any medicine or therapy that is out of reach to you because of your insurance or access to resources?
Um, yeah, when I have to go for total home care, my sleep apnea machine and stuff, the stuff that I need, the equipment and everything that I don't have the funds to pay for it. So it's just like I'm just left out that I don't have my insurance when I cover the medical card when I cover it.
Thank you, Shirley, for being with us and sharing your story.
Thank you for having me.
And with that, I'll give it back to Brett Chase.
I'd like to say, Shirley, thank you for
Thank
sharing your story. And Dr. JG will now introduce our next patient.
Thank you, Brett. Thank you so much. I'd like to introduce my patient, Mr. Adolphus Kindo, who I've been treating for sarcoidosis for some time now. I'll tell you this, despite his battle with this disease, I often will see him with a smile each time I walk into the room where he is in clinic. And I can't really begin to fathom the challenges that are covered by that smile. So I'd first of all like to say thank you, Mr. Kindo, for volunteering to share your experience with us on this listening tour. I can't forget the tremendous enthusiasm in your voice when I first mentioned the tour to you, and your willingness to help others understand the challenges that you face and lung health from your own perspective. So I'll start.
Well, it's known that you blackmailed me. You made me do it.
No, thank you for volunteering to do this. So, Mr. Kindo, when did you first realize you had problems with lung health?
I think it was probably in the last 3 to 4 years. It was purely by accident. Originally, there was a period of time in my life when I think I had a death wish and I really wasn't paying attention to my health. And I was living my life through the emergency ward. And in spite of, my knowledge and education, and then there was a period of time when I was out of work. And during that time, because I have congestive heart failure, my conditions became extremely worse. And I couldn't afford my medication. And so therefore I was, rationing my medication and, doing the best I could. This is before Obamacare and all the other interventions that came to be. And when I started working for the county and some other things changed in my life after the death of my wife, I then kind of focused more on my health. As a consequence of being treated for other issues, this came to be because it wasn't, my pulmonary was not the main reason why they were treating me, but sarcoidosis became known as they was doing other images of parts of my body, of my chest, and that came to be. And so it let me know that the importance of having dedicated health and being an active participant, because early on I was not an active participant. And my doctor asked me, did I have a death wish? And, was I trying to live? And I would imagine because I wouldn't change the way in which I was behaving. And so he was trying to introduce a medical intervention. And I would imagine that there are a lot of other Black men who are somewhat in the same position, who are using the emergency room as their principal source of how they're treating their other issues. And they may have sarcoidosis and not know it because they're not regularly visiting a doctor. And if you don't have the money and the resources, which at one point I didn't, and I kind of like refused to go. And so it was a combination of, some cultural thought processes, and at that time, again, not having the money and not really practicing a good primary healthcare doctor. So I didn't have a relationship with a doctor. And then as a consequence, you really don't know the other issues that you have. And I didn't realize I had sarcoidosis. I mean, you couldn't have told me that I had it, and that perhaps I had pulmonary problems. I wouldn't have believed it if you told me. And but it is because of those interventions and now having access to steady health care and a steady provider whom can give me wraparound services that these ailments became to be. I mean, I have enough ailments for an encyclopedia, but because I have such good health care and doctors, I've been able to overcome those challenges. And I try and stay positive, because if I focus on it, I wouldn't get out of bed in the morning.
Wow, that's very insightful. I'm sure, as you said, that your experiences can be mirrored by several Black males in the community due to these socioeconomic issues with misdiagnosis, and issues with trust as well. Tell me, was there any type of care that was really out of reach for you for a period of time, or was there any specific care that was difficult or challenging for you to get?
Well, without question, the detailed examination on the pulmonary side, without question, was out of reach for me for any number of years until I got permanent employment and the right kind of employment. I now have a PPO, and so consequently, I have no issues about when I go to the doctor, how many providers I can have, and medication. But before then, that was an extreme struggle, and I would never go to the doctor, and I certainly wouldn't have more than one specialist that I see. I mean, now I got like 10 specialists. And then, of course, I was using the emergency room as my doctor. So I didn't go to the doctor on a routine basis because I didn't have either the money or the willingness. And so there was part of me that didn't have the complete trust of the system. And so in some ways I created my own barriers. And then there were natural barriers of both education and, more importantly, economics. And so before there was county care and Obamacare as a system, and at the time, again, I was out of work, you would not really try and go to the doctor and have more than one specialist. My son, who since has passed, he at one point, my stepson, he was not taking care of his diabetes, and he refused to. He didn't have a regular doctor or a relationship with the medical system. See, it's important that you have a relationship with the medical system. And because so many of us, again, only use, particularly men, you only use the emergency ward as your principal doctor, you never really know all of these other issues that are affecting you medically. And so we don't know them until we are 40 or 50, and then we like drop dead.
Wow.
But these other issues were there all along. I mean, this lung issue was here. And if it wasn't for you and others, I wouldn't have known. And then consequently, I would have been making the wrong life choices of what I eat and what I do. I mean, now I'm like a fanatic of what I try and eat and the natural vegetables and other things that I do to try and help my healing. And I didn't really understand that early on in life. And well, it really wasn't that much earlier. We're talking about, 10 years ago. And so those interventions in my life and the intervention at the University of Chicago has saved my life. I would not be alive today without the intervention. I can say that for you for certain. I would be dead today.
Wow, wow. I can't even begin to imagine the challenges that you're encountering. And I can't even start to wrap my head around the socioeconomic, ramifications of what you're saying. And difficulties with insurance, difficulties with paying out of pocket and bearing these costs. I mean, these are real issues. How has your background, would you say, contributed to how you were treated in healthcare systems? Do you always feel like you were being treated with fairness and with respect, or has it been the other side, the flip side of this picture for you?
Well, in some ways, I lived in parallel worlds. So, 10 years ago, I didn't dress or look the same. And so on occasions, I felt as if I was just another number. I was just another guy in line that was going there. And then as I began to understand both the systems and interaction of people, I realized that when I go to the doctor, I wear a suit. If I wear a suit to a doctor's appointment, I get a different level of respect from the nurses and from the other people as I walk in the room, as I interact with them, how they follow up, how they treat me. I'm sure, perhaps it is just my one person perception, but it was, again, a perception that I come to realize in my life, at least. In my life, when I was, around in just my jeans, I didn't get the same kind of respect, the same kind of treatment as once it was understood that, one, I was working for the county, two, I had PPO. When you tell them you got PPO, it was like a gold card. And so therefore, a guy who comes in and dressed well, and got a PPO, then, they made sure they treated me. And sometimes, you wonder if you're a cash register. And so they really try and make sure that they give you everything they got to give. So, so that was a complete difference. And then I see how, because of the work I do, I work with many people who like work in the street. I spent 10 years as a certified gang expert. And so I see people in different conditions that others don't. I work with people who are, of course, on the street selling drugs and doing many other things. And while they're there, they never once think about their health conditions. So these people that we're discussing in the general broader community who otherwise don't have regular health care and are not interested in health care at all, particularly the men. They're just fighting for survival. And so, of course, when they come in with their pants down or however they look, they're not going to get the best advice. They're not going to get referrals to other specialists. I mean, that's not exactly what you're asking, but I'm trying to give you just a description of what I know that's in the streets,
Right.
in the locations, where, Death Valley and other places like that, those guys, they don't get referrals. They don't get treated. And I know from what they're doing, in 5-6 years, they gotta have the similar conditions that I have.
Right. Yeah, thank you so much. These are very profound observations. I can actually attest to it that I have never seen you without a suit in clinic in the last several years. So yeah, that is really, really profound. As an African-American man myself, I learned from a young age that you are dressed the way you dress. So I agree. It certainly, I do see that, and I think it's important. So thank you so much for your perspectives on this. I'll pass it back to Brett Chase. Thank you again.
Yes, thank you.
I'd also like to thank you for your story. Thanks for sharing with us. Dr. Arias will now introduce our next patient.
I would like to introduce my patient. His name is Marciano Gutierrez. He is Spanish speaking only, so I'm going to translate his story for us tonight. He's here with his wife, Silvia. The two of them are here. I met Mr. Gutierrez in 2010. He has severe asthma and severe asthma symptoms, and he's better today, but certainly his journey was full of difficulties, from losing his job to not being able to get his medication. But let's hear the story from Marciano. And I'm going to ask him the first question, which is, Marciano, how long have you had asthma and how severe your symptoms has been?
Empecé en mayo del 2010 con el asma y pues
Te ocasionaron muchos
me
problemas
ocasionaron muchos problemas.
porque no podías respirar, en tu trabajo era muy frío.
En mi trabajo era muy frío, no podía respirar.
Okay.
Estuviste yendo.
Marciano. Marciano is telling us that his asthma symptoms started in 2010, and he has daily symptoms. And he was used to working in a warehouse where his job was to store frozen packages of food, and he felt that the very cold environment wasn't good for his asthma either, so he lost many days of work. And let me go to the second question. What are the biggest challenges that you have faced in life with your asthma? Do you think it has been the lack of health insurance, language barriers, working conditions? Marciano, ¿nos podría decir las dificultades que usted tuvo con su trabajo y con el seguro? Como me contó lo que pasó con sus síntomas y pérdida de trabajo.
Bueno, mi trabajo era extremadamente frío. Se me dificultaba para respirar.
No podías controlar la ansiedad del frío en tu trabajo.
No podía controlar el frío en el trabajo.
Por lo tanto, cada rato te salías y tuviste muchos problemas con los supervisores, por eso.
Tuve problemas con mis supervisores porque salía cada rato.
Y eventualmente entiendo que le dio un ataque cardíaco, ¿verdad?
Sí, entonces...
En julio 12 te dio el infarto.
En julio 12 me dio el infarto, fui a parar al hospital, me hicieron una operación de corazón abierto, tengo
un stent
y 5 bypass.
Por lo tanto, ya no puedes
seguir. ¿Qué pasó en el trabajo?
Eso no pasó en el trabajo, fui a parar al hospital.
Por el extremo de frío.
Por el frío muy extremadamente, muy frío. Y pues en aquel tiempo tenía seguro médico y por falta de ausencias, así, por las ausencias que tenía yo, me terminaron mi trabajo, me quedé sin seguro médico.
Recién operado de la cirugía del corazón abierto.
Y después, recién operado del corazón, me terminaron, me quedé sin seguro médico. Mi esposa me tuvo bajo su seguro médico, y ahora...
Los costos del medicamento.
¿Podía conseguir las medicinas con el seguro de ella?
¿Manda usted?
¿Podía conseguir las medicinas con el seguro de ella o tenía que pagar mucho?
No, tenía que pagar mucho por las medicinas. En aquel tiempo los pagos eran muy elevados. En aquel tiempo, pues, más o menos, pues sí podíamos, ¿no? Pero ahora con el seguro médico que no tenemos, las medicinas cuestan bien caras.
Gracias.
112, 115, los inhaladores, o sea.
Ok, gracias, Marciano. Lo que Marciano nos está diciendo es que como su asma síntomas eran pues muy severos y todos los días, perdió muchos días de trabajo, eventualmente se complicó con un infarto cardíaco y perdió más días de trabajo y finalmente lo despidieron porque ya no por todos los días que había perdido. Entonces él perdió su seguro y cuando él perdió su seguro, tuvo que, su esposa todavía trabajaba y pues él estuvo en el seguro de la esposa y que la esposa pues tenía un seguro privado, pero el copayment de las medicinas era muy caro. I'm sorry for the confusion. What Marciano is telling us is that because of his asthma symptoms that got complicated with eventually a heart attack, he lost many days at work and eventually he was fired from his job. So when he lost his job and he lost his insurance, fortunately his wife was still working and he went under his wife's insurance. And she did have a private insurance, but he did have to pay copayments. And every inhaler, the copayment was almost $115 per inhaler. So he couldn't afford it. So he had no insurance now and he didn't have enough income to pay the copayments of the medications. Thank you. And the last question I'm going to ask is about how COVID affected both of you. Marciano, ¿cómo le afectó COVID?
Pues sí nos afectó muchísimo porque nos sigue afectando, porque en realidad no tenemos seguro médico. Mi esposa pues por segunda vez nos quedamos sin seguro médico. Mi esposa tuvo que renunciar porque había infectados, bueno, no sé cómo se diga, muertos, difuntos en su trabajo y por miedo tuvo que renunciar y se quedó sin trabajo también. No tenemos seguro médico y pues la medicina está muy carísima y gracias a usted, pues la medicina que me ha dado, pues eso nos está ayudando bastante.
Gracias, gracias por participar, Marciano. Gracias a los dos, a usted y a Silvia. What Marciano is saying that even though he lost his job and his insurance, but his wife was working, but after COVID, the job of his wife was terminated as well. So currently, both of them don't have any insurance. We have been getting by with samples that I give them, inhaler for the asthma, but now they are both in the process of trying to see how they are going to get some sort of help because both of them have no insurance at this time. And so he has been through a lot of hardship through, all this time with his asthma symptoms. And we are trying to help him now. Thank you, Marciano.
Dr. Arias, could you reiterate what he said about his working conditions?
Well, he was used to work for a warehouse where he was supposed to store frozen food. So he was always inside pretty much this cold temperature. And he felt that, this cold was no good for his asthma symptoms. And so he usually was worse at work. And he missed so many days of work that eventually he was dismissed. And he lost the job and he lost the insurance. And then he couldn't have enough money for copayment for the inhalers. And now after COVID, both of them have no insurance and no job.
Thank you. I often describe myself as a professional storyteller, and I can say these are very powerful stories. So thank you all. So now what we're going to do is open this up for a group discussion around a few key issues that we've mentioned. So some of these questions I'll direct at specific people in this group, but we all have different insights into some of these issues. We're all patients at times, so please feel free to share your experiences. So a question for the group. This question is for patients and clinicians, but remember, we're all patients at times. Please feel free to share your experiences. Have you ever had to make a sacrifice or a trade-off or know someone who has in order to have the resources you needed, such as medication or equipment? What did you have to sacrifice?
Francamente,
¿Puedo contestar por él?
Sí, por supuesto, Silvia.
Dentro de mi compañía, yo me puse a vender comida. Aparte de mi trabajo, llevaba platos a comer, a vender, perdón. Y pues los daba a bajo precio para que tuviera cosas, entrada pues, y esto es lo que me ha ayudado.
Gracias, Silvia. Gracias. What Silvia is telling us is very interesting story. This part I didn't know. She said when Marciano lost his job and he needed so many medications, and they did have a private PPO insurance, but the copayment was too high for them, so they couldn't afford it. So what Silvia started doing, she started cooking at home, and she will prepare sandwiches, a different food, and then bring it to her job, and she will start selling food in her job, you know, lunches, a snack for the other employees. So that was extra income to be able to pay for the medications, to pay the copayments for the medications. Thank you, Silvia. Gracias.
Any other patients like to weigh in?
Well, and also just to remind everyone, we're all patients at some point in time. So I think, you know, we can all think back, you know, where were those times where, whether it's us or a loved one, we know that may have had to pick something else, right? I will admit there were times, right? I had a job and good old 2008 hit, and you start making choices, right? And so was healthcare one of them for me? No, you know, so my trade-off was making sure I could pay rent and get food, not so much pay for COBRA, the unemployment insurance. So it can hit anyone. And I think we need to recognize, again, it comes in different forms, and those trade-offs can be extremely difficult. And you hear, you know, the idea of having to sell extra food just to pay on co-payments when you have insurance. It's brutal.
Well, our description is, at what point in life do we have trade-offs between healthcare and our medication? I mean, our money. I mean, some of that was also a function of age. When I was younger, I never really worried about healthcare. In fact, I spent less time. I mean, never went. And but then when I got out of work and became a diabetic and had congestive heart failure, and I couldn't get my diabetic medication, and then it became a critical choice between, before I had insurance again, how I got my either heart medication or diabetic medication and how I would pay for it. And there was a lot of things I wouldn't do that I stopped doing for the kids, that I stopped doing for myself. And it also made me have to hustle more. I had to figure out how to get the money in the door, you know, to pay for it. But it definitely had a deleterious effect on my health. And yes, we make those choices, and sometimes they become more critical as you become older, or as you become, you know, more sick and you don't have health care. So without question, if you don't have health care, you are making those kind of choices if your medication is your only means of survival.
That's really great. Thank you so much for that perspective. So in general, I would say that a lot of weight is placed on the clinic encounter when we get into clinic and encounter patients as clinicians. Whether we as individuals adhere to the recommended treatment plan or care plan depends to a large extent on our relationship with our clinicians, the care providers in the clinic setting. And so my question to patients is this, in a broad sense, and I'll probably direct this to Shirley in particular, so I can hear from her as well. What kind of relationship do you have with your clinician? Can you tell us a bit more about your relationship with the clinicians in the healthcare setting? How much of it is built on trust? And just in a broad sense, what kind of relationship do you have with your clinician?
Dr. Kumar, she's my primary doctor, and I love her. She always been there ever since I became her patient. She was right there, no matter what. She reminds me of my mother always on me. No, you got to do this. You got to do that. So, well, that is the thing that I wasn't having any kind of money coming in at all from my job, nowhere. And so I have my grandkids. So I'm raising my grandkids. I have my 2 granddaughters. So they was keeping me going. So I started baking cakes and pies and stuff like that. And I was selling them just so I could have some kind of income coming in to at least help them out too as well, and try to pay my pay code at the hospital, because when last week I was at the hospital, they said my copay was $75. I'm like, oh wow, why do I have a copay? And my insurance supposed to cover that. They was like, well, I don't know why you have a copayment. Every time she said, well, next time you come, your doctors might reject you because you don't have that copay. I'm sorry, because you don't have that copay. So I said, oh wow, what am I gonna do? So I get a call from Loyola billing department yesterday. She said your insurance is not paying for your for you to visit a doctor to come here. They haven't been paying for the last 3 months. I'm like, oh wow, what am I gonna do from here? So she gave me a number to call, and Blue Cross Blue Shield Medicare. And she said, well, call them and try to get them to update it, and then call her back so she can update her system. When I go back to the doctors, I don't know how's it gonna work out. Is they gonna ask me for another co-payment? I tried to get in touch with them, so I don't know. From here on, I don't know if I'm gonna be covered when I go back to the doctor.
Thank you so much for sharing that. That was very, very helpful for us to understand from your perspective. Can anyone just volunteer the information and tell us when they knew that their clinician relationship was built on trust and that their clinician provider had their best interests at heart? Because a lot of this really is based on trust between the patient and the clinician. And I think looking at how important this factor is, we would love for it to sort of play a role earlier on in the relationship and not much later. So can anyone just volunteer and just let us know what their thoughts are about the primary importance of trust and how early that relationship was built on trust for them?
Trust with my clinician was really critical in my willingness to follow their instructions and to work with them. I mean, when, they would sit there and say, well, here, this is my cell number, call me if you need me at any time. No. If they would, when they're talking to me, would, really take a moment to pay attention to me and not just, give me my 5 minutes and send me out the door. So there is a difference in the bedside manners and how people treat you and how you receive that information, how you code and decode that information that's been told to you.
Thank you for that. Is there anyone else who wants to share from a patient perspective about trust?
Now, I could say that at some point, at one point, I made sure to always go to the older doctors than the younger doctors. Because there was a point that the older doctors were willing to spend more time with me and to spend more time like focusing on the details of what you said and what they observed, as opposed to only, and the younger doctors were more interested in getting you in and what they had to input on the screen and kind of moving along. Now, I've begun to find some doctors who were more of a combination. And so, although they may be younger, they tend to have more of a, an older perspective. And so I kind of look for those kind of doctors when I am going through the system. So, I mean, quite frankly, there's some doctors that I end up canceling and I look for others. Or I talk to some doctors and they give me some recommendations, and that's kind of how I choose who ends up being the doctor that I'm working with.
Yeah, that's a very important point you just brought up, the attitude of the clinicians or the care providers and how that impacts that relationship between the patients and their caregivers. So I'll say that we as clinicians are often on the flip side of the coin as care providers. While certainly we are trained to be objective in our approach to administering care to patients, how our counsel and advice is taken depends to a large extent on trust. And so I'll ask the clinicians on the call this question. As clinicians, as care providers, how do you know that you have an open and trusting relationship with your patients? This is specifically for clinicians on the call. How do you know that the relationship between you and your patient is open and it's a trusting relationship that will foster care?
With one little caveat, it's okay to say you don't know all the time if you have such a great relationship with your patient, and that no one's going to judge you for it.
You know what? I think that's such an important aspect of a patient-clinician relationship. And just like any other relationship we have, you have to put in time and get to know that individual and treat them. I think in my experience, whenever physicians sort of tell patients that this is what you need to do, more often than not, you will have a patient that will not follow, or more importantly, actually will not take care of themselves. So, really, that has to be, a relationship where it's a shared decision. And I think that Dr. Deji also just pointed out, really, I think it's important to see the patient as a whole. And there might be some give and take. There might be some things that you have to adjust, compromises, and eventually develop that relationship that really translates into trust. And both, I feel, it's important for both, for patients and for physicians, that trust aspect.
Wow, that's very, very insightful. I think you touched on a few important points. One of them was putting in time, and it sort of dovetails with Mr. Kindo's point as well. Putting in time for your patient to foster that trusted relationship between the clinician and the patient. It's incredibly challenging in 2020 to do that. Calling patients outside of office hours to develop that relationship with them is so much more difficult than it used to be. And one thing Mr. Kindo said was, when patients come into the room and the clinician is just typing away at the keyboard and not maintaining eye contact and just feeling like there is a human being there. So that trust fizzles away right away. And we see it a lot of times now in this era of trying to get patients out the door. And so I think that those are very real issues that can impede that relationship of trust between the clinician and the patient. But I'm sure there are many more. So what else can we do? What more can be done to ensure that more healthcare providers are working to build a really strong relationship that helps the patients and helps them get the care that they need? Does anyone have any ideas? What more can we do?
Yes, I would like to add that I think, this trusting relationship is extremely important. And like everything that is important, we have to work very hard to get there. And I thought it's very interesting what Mr. Kindle just said. And it's the time that you spend with the patient. And it's very important that the patient realize that you are looking at the patient as a whole. So he just came to the office not just to get a diagnosis and a prescription, but the physician is going to ask also, and who takes care of you at home? Who do you live with? Who watches for you if you get sick and an emergency happens? Who brings you the medications? Do you remember to take them? Do you understand what kind of disease you have? Do you understand why you are taking this medication? Why it's important? And I just prescribe the medication. Are you going to have a copayment for this? Do you have enough to pay? Maybe I should change to another medication, something that you can afford. So the patient leaves the office knowing that he was taken care as a whole. Not only he got a diagnosis, he got medications, but he understood why he's taking those medications. He understood what disease he has. and how that disease is going to get better or is going to get worse. And he also has the reassurance that, he has people around that are going to support him in need. And the doctor also prescribe medications looking at what he can afford and what would be good for him. Because many medications are similar, and the best medication is the one that the medication not only works for the patient, but also the patient can afford it. And all these aspects need to be looked into. And if the patient knows that they look into all of that, that's how the trusting relationship develops.
Wow. That's...
Now, one of the things that I would share with you that I learned on the street, you have roughly 3 to 10 seconds when you first see someone to look at them in a way in which you convey trust in your eyes. I mean, I once walked into Robert Taylor and the guy had a pearl handle Magnum pointed at me. And I kept my eyes on him and looked at him and tried to communicate that he could trust me. So I learned in the street that you got to establish correct eye contact and voice contact in order to, and using that nonverbal communication in order as a way of commanding and communicating trust. Now, of course, you can't make it, but it is your way to begin to set those parameters. And I assume that doctors already know this, but I'm only communicating to you what I've learned in my interactions with doctors and what I've learned on the street and what I've used in when I'm meeting with doctors to see, if they know that, then I know that they are the kind of doctor I work with. If I don't, then I have to make a decision.
Absolutely, absolutely. So the eye contact and the voice contact to maintain that connection between the clinician and the patient, make them feel like they're a human being. And I also like what Dr. Arias also talked about when she emphasized the need to touch on issues that matter to the patient, not issues that matter for the diagnosis alone, but you're trying to view the patient as a total human being and not just a specific disease. So asking questions that are critical, that show that you can connect with that patient. I think those also help to foster trust. Those are really great points. Thank you so much for that. I think Louis Giles had a question as well, or a comment.
I'm a pediatric pulmonologist at the University of Chicago. So of course I take care of children with severe lung disease. And a lot of the disparities that every single one of you has commented on is certainly something that I see day in and day out in my practice. The one comment I was going to say, because you're asking about trust, and not only do I have to build trust with the child, I have to build trust with the parent or the guardian of that child who is my patient. And I think that Mr. Kindle, you mentioned that good eye contact and voice contact is important, and that's especially important in children. But I find that just spending some time just to find out a little bit about them. So in my era, or in my role, I say, like, what grade are you in? What do you like to do at school? What is your favorite class to do? What sports do you like to do? What do you want to be when you're all grown up? And just things like that. And then I jot down little notes so that the next time I see them, oh, how's that dream of becoming a firefighter going? And just things like that. And just trying to build that rapport, I find is so important. I find it's important because it tells me what the kid wants to be. If they sit there and they say that they would love to be a policeman, but they can't because of their asthma, then I can talk to them about that. Or I'm having troubles with my sport. I want to be a basketball player. But when we talk about basketball, finding out that their asthma is not as well controlled, and that kind of thing. So we get so much more. As to how well they trust me, I don't know. I'm not living in their minds, but they keep on coming back to see me in clinic. So I take that as a good sign.
Very well said. Very, very well said. Thank you so much. Those are all wonderful points, I think, in the process of building trust between the patient and the clinician. So thank you so much for those thoughts and comments. I really appreciate it. I'm sure the group does as well. I'll turn this back to Brett Chase to continue. Thank you.
Thank you. I'm just going to throw one more out to the group, and that is just, why are these issues occurring more often among people of color, and why, in vulnerable communities?
I think one of the things that I see in my patients is the fact that they have, they have to balance their healthcare and the cost of healthcare to, trying to find, time to take away from their work. And a lot of times they're looking for their clinicians to be advocates to help them with paperwork. And, all of us are short on time. And I know that, for example, with Shirley, I think in order for her to keep her FMLA and her coverage, she needs paperwork to be submitted every time she comes, and she has to be seen, for every extension of trying to be away from work so that she can focus on her health. She requires that commitment from her clinician and support from, the other staff in terms of answering her messages and so on, so that, we can help them in their in their struggle to kind of hold on to their health insurance and work-related paperwork that's sometimes needed to support them.
Can I add something?
Please, please.
Hi, I'm Latisa. I am a clinician, an educator, and was recently a patient in the hospital about 4 to 6 weeks ago. And my issues were I had lung issues, I had pneumonia, I had COVID, and other things that were going on. And we talk about trust. And I was in a community where I did not look like everyone else. Okay. There were times where I didn't see a clinician. There were times where I received a phone call from a physician on the phone, and they would assess me that way. I had times where I had clinicians that would come and actually examine me and touch me and look at me and just have a conversation. And what I want to say is, because there is an elephant in the room sometimes, and we're not all the same. We all have a story to tell. We have backgrounds, and in that story, we will see that sometimes we're threaded the same, right? Sometimes we have some commonalities that are important. And what we have to understand is how to connect. And we talk about eye contact and things like that. But just to find out a level of understanding, as I was in the hospital for about 9 days in the hospital, it wasn't until the 4th day, and I never told anybody I was a nurse of 25 years. First of all, I was too sick and I didn't get that story out. But I was treated differently from those 4 days to the 5th day, when they found out that I was a clinician, how many years and how much knowledge I knew, that I was a nursing administrator for over 18 years, that I was an educator for over 6, right? So then things started to change in my world. People started to come in, people started to talk to me, look at me, examine me differently, and that is very powerful. And I think about Mr. Kendall and his description of, how we look sometimes and how people perceive us. You never know. I mean, my mother has made a lot of money. I mean, she could come to the doctor with just jeans and a hat on, and they think that she might not be able to afford healthcare, right? And she's like, I can afford whatever anybody else can afford. And then you have another person who can't afford anything, but no one has listened to their story. So I think as far as clinicians are concerned, and I'm a clinician, that we have physicians, there are some physicians that came into my room, I will never go see them. Never, because they have not built that trust. There are times where I've traveled over an hour to see a physician because of that trust. Because yes, they said they might not have given me their phone number, but maybe they've given me their email, because they're always on email. Listen, if you have a problem, email me. They take the time, they educate me. And if physicians have only a 15-minute window, then we need to do a 5-minute assessment. In the other 10 minutes, I need to know how you are. I need to know more about you. I need to take the time to educate you and make sure that you have received the education, you understand the education that I'm giving you, and that you have the resources that matches up with your story. That's it. That's all I have to say.
No, we appreciate that. I'm
Can
glad
I
I'm
can I
glad you
add
spoke up
something
on that.
as well?
Yes, please. No, please.
Thank you so
Thank you.
much. My name is Miriam. I'm a medical assistant at Community Health Clinic. Community Health Clinic is the largest free clinic in the USA. We are volunteer based. We serve mainly to people that don't have health insurance. So I invite you all to spread the word. We are located in West Town, and we provide services from dental to in-house specialties, uh, you name it, going from primary care service. We have gynecology on site, we have nephrology, we have neurology, we have ophthalmology. We basically, our main number of patients that we see daily are Spanish speakers and Polish. Um, but everybody's welcome once they don't have any health insurance. One of the things that I want to share, and I agree with the previous comments, is how important is the bond, the trust that you build with the patient. And I think important thing, how do you make them feel? I do assist nurses and doctors on site. I do also take care of different other items like spirometry. I do a spirometry test. I do a smoking cessation consults. And it's amazing to see how when you have eye contact with them, when you spend time with them, when you use simple language to them, you can see how comfortable they feel. And overall, they are feeling more comfortable and they come back to our clinic. We also have social services. So we have been able to, through the communication that we build with them, help them in many other ways, not only physical health, but mental health as well. Important, I think it is, like they were mentioning before, eye contact, giving them time to express themselves, asking about how are you doing today? Simple questions like that means a lot to them. So I agree, communication is just simple as a building bond between the clinicians, the healthcare center, between them and the patient. So thank you very much for important what we are learning tonight.
What I wanted to say, Dr. Ku, about the trust and how I built a trust with Dr. Kuma. I'm at a point where I can open up to her and I can talk to her about anything and she would listen. For example, I was hospitalized, 3 weeks ago, and I was at Dr. Kumar. I went to see her for my doctor's visit, but she was like, no, I'm gonna have to admit you. I'm like, Dr. Kumar, I can go home and take my treatment, take my spray. She said, no, you're going straight to the emergency room. So she called the ambulance, and so I went over there, and when they admitted me, she had the best team to take care of me when I was in there. So she had told them to make sure that not to send me home unless I'm on a 30 milligram on the prednisone, the steroids. So get back to the trust. I go back to see her, and so I'm asking her, I'm like, Dr. Kumar, I'm opening up to her. I'm coming to her just like she's not my doctor, somebody I can talk to. I said, well, Dr. Kumar, do you think that I would be able to go back to work because of this COVID and my signal, my lung disease, and I'm a diabetic now? And so she was like, well, we don't know right now, but I'm not going to send you back because I'm a customer service manager at Walmart. So I have to deal with a lot of people. So she gave me a straight answer. She was like, well, we don't know right now. So I'm at a point that I could trust her and I could come and talk to her about anything. And that's good to have a doctor like that.
Oh, well, that's amazing, and I'm glad we're bringing that up. And I actually want to bring it back to what Mr. Kindle had said about the suit, only because I know there are a lot of people listening, and I know for some people they heard it for the first time and they're like, oh man, just like, you know, when people hear that parents have to talk to their Black and brown children about what it means to have a conversation with police, and it's always this look of shock, and you probably saw me nodding my head, which is, yeah, I had that conversation about why I wear a suit when I travel, why I wear a suit, right, when you have these important meetings. That unfortunately is the way of life for many folks, and the point is we shouldn't have to wear a suit to build trust or a relationship, especially in situations where there is a different power dynamic, right? And we have to not only recognize that power dynamic, but we should actually expect more even when we are lower on that pedestal. So if, you know, you have a clinician with this authority and they have the skills to help you, that doesn't mean that we look at them and we give them a break. In fact, we should have higher level of expectations for them, for how they are treating us. And I can give, you know, the one small example, and I admit that, you know, even me with the work that I've, you know, learned over the years with chest, my primary care clinician knows that I work with chest. And when she treats me, I will admit she's a typical heads down and I just go on and I don't really mind, but I should. But the point where it really comes up and I notice the difference that she has is she knows that I work for chest and she knows many of the clinicians that I work with. And so when it comes to my asthma, I admit I have asthma, all of a sudden it's a different conversation. She looks up at me and goes, oh wait, so we should talk about it, because she knows that I might go back to the pulmonologist I know saying, is this really the right treatment that I should be having? But the point is, she shouldn't necessarily change the way she treats me because of my knowledge or because of who I know. She should change the way she treats me because who I am as a person, and that's what I deserve. And so that level, that expectation setting that we have that continues to drop because of the disparities we see, that has to change, right? When we get a Dr. Kumar or Dr. Diamond or Dr. Desai and Dr. Deji, Dr. Arias, all of you are phenomenal clinicians who have brought forward many of your patients, right? That is the standard. And I think for a lot of people, they feel when they get that care that all of a sudden they've reached like the pinnacle. There's the icing on the cake. And we're like, no. The bare minimum is what you see from Dr. Kumar and others. But why don't we see that from the rest of society? And I know that y'all, everybody here does that. But I think the question that I want to throw out there is, what are we going to do to change that level of expectation that all the clinicians that we have on here that do such an excellent job, why aren't we bringing that forward with everybody else and saying that's the level of expectations that we have for our provider, as well as our patients to ask of that of their providers?
Thank you. We're running out of time here, so I'm going to toss it over to Kim French at this point.
Thanks so much, Brett. You know, I'm really honored to have been included in the Chicago listening tour tonight. Not only has this event been enlightening, but really it inspires us to find better and more sustainable solutions for our patients and our communities. It resonated with me personally. As a cancer survivor, I really found it interesting that I had a lot of the same concerns about losing my health insurance, which I was carrying for my family at the time, as the patient in the beginning that had the same concerns. So I really connected on that. It's clear we have a crisis in Chicago, and COVID has escalated that crisis to even higher levels. So let's recap what we learned tonight about our crisis. Those who die from lower respiratory disease are more likely to be African American. The incidence of asthma in the city's low-income neighborhoods is almost twice of that in high-income areas. In Chicago's low-income neighborhoods, we have up to a third of residents that have prescription medication that they cannot afford due to cost. Our poverty levels and percentage of people without health insurance are well above the national average. It's shocking what we have going on in Chicago. We have to fix this. We will be visiting really with each of you to find solutions that are sustainable. I want to thank everyone who participated tonight, those who just tuned in to listen, and particularly those patients who shared their voices and their stories on a very deep and personal level. We value each one of you and what you brought to tonight's event.
Yeah, thank you so much, Kim. Really appreciate that. I want everyone to know we're not done listening. This isn't a, it's not just a photo op for us. This is real work that needs to be done to create real interventions that can make a difference, that are sustainable to our community. I think one of the interesting things I've heard recently is it's around the word inclusion. Inclusion means you get invited to the party, but it doesn't mean you necessarily feel like you belong there. And I think one of the things that we can do is start working on creating that sense of belonging through the work that we do here on building trust, building access, and devising ways to create equitable resources for those who need it. And what I encourage all of you is to help keep us at CHEST, especially me, accountable to continue this conversation. You know, we started this in Jackson, Mississippi just a few weeks ago. We've already had one in New York City, and obviously we got to do this in our hometown of Chicago. And so I do want to let you know that the conversations are continuing to build off one another to find meaningful ways of us to make a difference in the community right now, while at the same time for us to do everything we can to raise the profile and the conversation and the voices that we've heard today and the many other voices we know that are still out there, that are still suffering, because we don't want people to feel that that is a one-off conversation or a one-off story, right? Unfortunately, those stories are not just analogies we reference in newspaper articles. We want people to understand the statistics and how that truly affects everyday life. And so moving forward, you will hear from us. We will be pulling together a Chicago report, not only based on the conversations we've had today, but other conversations with folks that couldn't necessarily be here today, with other community organizations that also have a great perspective. I saw a lot of great comments in the chat coming through. There is so much more to be had. And so I do want to let you know there will be further conversations with many of our community leaders and those that want to come together to support the things that we need to do to make a difference, especially those suffering from chronic lung disease in the Chicago community and beyond. So I really appreciate y'all being a little vulnerable for us to have an open conversation, knowing that it's leading to the next conversation, because that's the only way that we're going to make a difference is by continuing the conversation and not letting it die out, not letting it to go into a deep, dark corner, but to bring it out into the light and pull together the right community. So thank you so much again. Really appreciate it.